I recently came across a news article that disturbed me greatly, especially since a few similar articles had been already published in the weeks before. What was it and why was it disturbing? Stay tuned to find out. This is an excerpt of the article, which was published on the 7th of June 2025. It reported that a certain breast clinic had performed more than 6,100 breast cancer surgical operations since 2010 and over 450 in 2024 alone, indicating that it was involved in a high volume of patient care. It then went on to state that one of the clinic's latest innovations is endoscopic breast surgery that combines keyhole mastectomy with immediate breast reconstruction. The first patient to do this operation was a patient who was diagnosed with stage 1 breast cancer in 2024. Doctors are always innovating to find new and better ways to treat disease. So what was it that I found disturbing about this article? Allow me to elaborate, and I will consolidate my thoughts at the end of the video. Before we move on, I will explain some of the terms used in this news report. Endoscopic breast surgery is an operative technique which requires special expertise and instruments to perform surgery through smaller incisions. This is often called keyhole surgery. If the breast is removed using this technique, it is referred to as keyhole mastectomy or minimally invasive mastectomy and is performed with immediate breast reconstruction. In the context of the news article, the pertinent question to ask would be whether the operation called endoscopic, keyhole, or minimally invasive mastectomy is the best way to treat breast cancer. In order to answer this question, there are 3 main issues to be addressed, which I will do next. As always, the content in this video is solely for educational purposes and not intended to replace a medical consult. Please see your doctor for treatment planning. That said, to put keyhole mastectomy in perspective, I will share briefly how conventional mastectomy is performed. Conventional or traditional surgery removes the breast through a standard incision as illustrated on the left picture, which results in a scar that looks like the one shown on the right. When performing conventional mastectomy, an ellipse of skin is removed so that the remaining skin will sit flat on the chest wall after the breast has been removed. This requires a fairly long incision, which expectedly leads to quite a long scar. Through the use of special instruments developed in the last few decades, the breast can now be removed through much smaller incisions, which can be placed in positions where they are less obvious or hidden. This is an example of the result with a technique which this team of surgeons refer to as reverse sequence endoscopic mastectomy. The red arrows indicate the scars. This operation requires immediate reconstruction, as unlike conventional mastectomy, the skin overlying the breast is not removed. Therefore, if reconstruction is not performed, there would be redundant skin which would sag down in wrinkles over the patient's chest. It is natural to ask the question if you should undergo keyhole mastectomy as this patient did if your doctor has offered it. If this is a situation you or someone you know has encountered, may I suggest asking these 3 questions before deciding on the operation that suits you best. As a surgeon with more than 3 decades of experience, these are the questions I would ask my doctor if I were offered the option of this treatment. Firstly, I would like to know what the current recommendations for the surgical treatment of breast cancer are. Secondly, I would like to know the available research data regarding the procedure and how it compares with the current treatment standard. And thirdly, if there are any disadvantages to undergoing this operation. Let's look at the answers to these questions. For those who have subscribed to my channel and watched a few of my other videos, thank you very much. You would already know that the options for the surgical treatment of breast cancer can be broadly classified into 2 groups. If suitable, patients may choose to undergo breast conservation treatment. This involves the complete removal of the cancer, usually with radiotherapy to the remainder of the breast. Patients may also choose to undergo mastectomy, which is the other option involving the surgical removal of the breast, and may be followed by reconstruction. With respect to the current recommendations for the surgical treatment of breast cancer, in 2025, this panel of international experts issued this consensus stating that while they support patient choice in the decision of the type of primary breast surgery, they also believe that patients should be advised that breast-conserving surgery and radiation therapy is usually the best treatment option with comparable or superior cancer control results, less morbidity, fewer complications, and favorable patient-reported outcomes. The experts imply that breast conservation treatment should be considered as the best option over mastectomy, regardless of the technique used, whether through conventional or keyhole surgery. There is not much research data comparing conventional breast-conserving surgery and endoscopic mastectomy. The number is insufficient to come to a strong conclusion to make general medical advice, so I will have to collate data from research performed separately. I will then discuss how the information can be used to make some comparison based on my own experience as a surgeon. It is known that conventional breast-conserving surgery is usually done as a day case, or patients may be monitored overnight and discharged the day after surgery. Breast-conserving surgery may be performed under local or general anesthesia. Pertinent to our discussion today, I wish to point out that unlike breast-conserving surgery, endoscopic mastectomy cannot be performed under local anesthesia. This study is highlighted as it provides us with some idea of operating time for breast-conserving surgery when performed under local or general anesthesia. The median time taken to complete conventional breast-conserving surgery was reported to be 45 minutes when performed under local anesthesia and 61 minutes when done under general anesthesia. The maximum length of hospital stay, whether surgery was performed under local or general anesthesia, was reported to be 29 hours. Let us compare this operative time and hospital stay with those for endoscopic mastectomy with reconstruction. This is a meta-analysis of the oncological, surgical, and cosmetic outcomes of endoscopic versus conventional nipple-sparing mastectomy. I wish to point out, firstly, that this study does not compare mastectomy with breast conservation, and that this is data from surgeons who already have experience with endoscopic breast surgery. Operative time is between 185 minutes and 451 minutes. If we recall, the longest operative time for breast-conserving surgery was 70 minutes. In other words, endoscopic surgery with reconstruction took between 115 and 375 minutes longer to accomplish. The mean hospital stay was between 6 and 14 days. This is compared with a longest hospital stay of 29 hours for breast-conserving surgery. In this analysis, the estimated incidence of overall complications for endoscopic nipple-sparing mastectomy was 16.54%. This is compared with reported estimated risk of complications with breast-conserving surgery of 1.74%. Here is one of the few studies which compare conventional breast-conserving surgery with endoscopic mastectomy. This study was published in 2017. While it was reported that the operative time of endoscopic nipple-sparing mastectomy with immediate implant-based reconstruction was longer than that for breast-conserving surgery, there was no difference in other factors, particularly in disease-free survival and overall survival rates between the two groups. The group of patients who underwent endoscopic mastectomy were reported to be more likely to experience a satisfactory breast appearance. Here is the comparison of the appearance after endoscopic nipple-sparing mastectomy and breast conservation treatment. Please make your own judgment as to whether there is a significant difference in appearance after endoscopic mastectomy with immediate implant reconstruction in the upper two photographs and breast conservation treatment in the lower photograph. This is a study comparing robotic versus conventional or endoscopic assisted nipple-sparing mastectomy and immediate prosthesis breast reconstruction. Robotic mastectomy is also a keyhole procedure using a different set of instruments compared with endoscopic mastectomy. While several parameters relating to the use of the three forms of operations, robotic-assisted, endoscopic, and conventional mastectomy were evaluated, my objective in discussing this study is the cost analysis in the year 2024. Both robotic and endoscopic mastectomy were more expensive than conventional nipple-sparing mastectomy. In addition, there is also data to show that the cost of oncoplastic breast-conserving surgery is lower than that for mastectomy. Although I could not find a study that directly compares the two forms of surgery, by inference from these two studies, we can conclude that the cost of breast conservation treatment is lower than that for keyhole mastectomy with immediate reconstruction. This first patient who underwent keyhole mastectomy with immediate breast reconstruction at this breast clinic was diagnosed with stage 1 breast cancer. This stage is defined as T1, which is a cancer size smaller than 2 centimeters without any lymph node involvement, which is denoted as N0. In 2016, a team of doctors from the Netherlands found that there was a significant difference in 10-year distant metastasis-free survival in favor of breast-conserving surgery plus radiotherapy for patients with stage 1 cancer. This more recent study, published in 2025, corroborates data from the earlier study, specific to women with triple-negative breast cancer and stage 1 disease. Those who underwent breast conservation treatment had a lower local regional recurrence, abbreviated as LRR, than those undergoing mastectomy. Based on the research data which I have presented in this video, here is a summary of the comparison between endoscopic mastectomy and breast conservation treatment. This information would help us answer the third question about disadvantages of the procedure. As a surgeon, my primary concern is my patient's long-term survival. Post-operative complication rates, operative time, and hospitalization are also factors which would influence my recommendations. Cosmesis, while important, is slightly lower on the list of considerations. Healthcare costs are a concern today and should be taken into account for treatment decision-making. If this does not provide a sufficient hint to my preferred recommendation, please watch the other videos on my channel. Thank you for staying until the end of the video. I hope the content has been useful enough for you to like, share, comment, and subscribe. If you wish to have more clarity on the data presented here, please submit a request on the link provided in the description. I look forward to having you join me in my other videos as well. Until we come together again, take care.